everyone. I'm Cheryl Koehn. I'm with Arthritis Consumer Experts, and we're hosting the hashtag #CArthritis event. The Canadian Rheumatology Association and Arthritis Health Professions Association annual scientific meeting just concluded, but we're tacking on saving the best for last, or near the best for last, Dr. Diane Lacaille. I'm so thrilled, Dr. Lakay, to have you here in studio with us and helping us bookend this fantastic 8th annual event that we hold as part of the scientific meeting. So thrilled to have you in the studio.
It's my pleasure, Cheryl. Thank you.
Fantastic. I'm going to tell the audience a little bit about you, Dr. Lakay, before we dig into our conversation. So folks, we're sitting here with a very famous doctor, researcher. Dr. Diane Lacaille is the scientific director of Arthritis Research Canada and a senior scientist there. She's also a professor in the Division of Rheumatology. She heads she's the associate head of academic affairs in the Department of Medicine at the University of British Columbia. She holds a clinical practice in Vancouver, British Columbia, and also is the chair of the Mary Pack chair, pardon me, in rheumatology research of UBC and the Arthritis Society. So that's a mouthful. There are a lot of things going on in your life, Dr. Lakay, and we are so happy to have you here. We know that many, many years ago, BC stole you from McGill University, and you're now, I think we can fairly call you a Vancouverite, can't we?
A Vancouverite with a Montrealer at heart.
Absolument, absolument.
Ça reste toujours proche du cœur.
Ah, merci. We know that your bench strength really is in clinical epidemiology. You've done years of work in rheumatoid arthritis, in looking at what happens to people like me who live with rheumatoid arthritis in the workplace, in broader community settings. You've done tons of work with Indigenous communities. Your work just spans, I like to say, all of the really people-y stuff, like all the stuff that really matters to people like me, stuff that's super applicable and important, and was before your arrival onto the research scene. We knew nothing about what was happening with people with RA in the workplace, yeah. Or up in our Indigenous communities. So I want to thank you for that, and also acknowledge that you and I are blessed to be on the land of the Coast Salish people. We gather, live, and work here. It is the traditional, ancestral, and unceded territory of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh. So I know we're both very grateful to be here speaking together on this beautiful land. So we're going to talk today, Dr. Lakay, about something very specific that you and I were on a panel at the annual scientific meeting of the Arthritis Health Professions Association. And that's really about bias, and bias in the healthcare system, and both conscious or unconscious or implicit bias. I mean, there's lots of ways to talk about bias, and you're going to shed some light on that. And really, this topic, we talked about it last week, to really push forward on our path to equity and inclusiveness in care delivery in Canada, and specifically in arthritis, where we know inequities exist. So I'd like to, I guess, start off by asking you to maybe give us that brief definition of bias, and how does it affect the delivery of healthcare?
All right. Well, thank you, Cheryl, and thank you for the opportunity to speak about this. I think, you know, as you mentioned, as I've done work around the quality of care for people with arthritis, it's very obvious that a lot of inequities exist, and we have to do a lot of work if we want to be achieving equity. And equity in care delivery means that there's inequitable health outcomes, and people suffer in a way that's completely unacceptable. Sorry, just a little preamble. So you know, biases is something that we all have to become so much more aware of. And I think it's really important for people to not dismiss it and not say, oh, I have no biases because I'm not racist, I'm not sexist, etc. We have to recognize that we all have biases. They stem from our upbringing, from our personal experiences, things that have happened to us over our life, things that have happened to the generations before us that we carry as the history of our people, from society around us, the books we read, the movies we watch, the music we listen to, etc. It's everywhere.
Yeah.
And I don't want to focus so much on the explicit bias, which is the overt intentional bias of when people have some beliefs that they are completely aware of, that they believe that certain groups are less worthy or are inferior. I'm talking about the implicit bias, the unconscious one, the ones where people have automatic thoughts that they're not even aware of, but that unfortunately those thoughts influence how they perceive, but even more importantly, how they act towards certain groups. And that, as a health professional, is completely unacceptable. I mean, we start from the premise that we offer the best care to everyone. So if we have unconscious biases that come from our personal life that influence how we provide care, we need to do that personal work to unpack those biases.
Absolutely.
And to recognize them, because when something's automatic, until you recognize it, you can't act on it.
It's almost like deprogramming yourself in some ways. And I'm thinking,
I love that. I love that word.
To you,
It's
Dr. Lakay.
deprogramming.
Yeah, I'm listening to you and I'm thinking, well, what sort of the number one thing we as patients know is that you swear a Hippocratic oath when you get a license. And the first thing is do no harm. Well, bias does harm.
It does.
Bias does harm. Yeah.
Yeah. And, I think people tend to think of the more obvious biases, like the biases on race and on gender, but and on sexual orientation or gender identity. But there are a lot of other biases, biases against religion, but also biases against weight and age and disability and socioeconomic status, education, even biases due to beauty, that we treat different people differently in our interactions that can affect, and biases can affect in so many different ways in the context of clinical care. It can affect what I offer to a patient as a treatment, or what investigations I might decide to do. It also affects how I communicate with them, but it also affects the receiving end. So how I interact with a patient interacts how connected they feel, how much they will trust the advice that I will give, how adherent they are going to be to what I prescribe or what I recommend, how likely they are to come for follow-up. So, a lot of those things that then people say, they put that responsibility back on the patient, are actually really dependent on what I did and how I interacted and how I created that relationship.
So it's taking personal responsibility as a healthcare provider for a lot of that.
So I think, and so in terms of what we need to do as clinicians, we need to think about our personal biases, but we also need to think the biases that are at the organizational level and at the system level in our practice, so that we, deconstruct those biases, and that we, that we dismantle this. And, we talk also about power and privilege. And I think we have to recognize that as a physician, and so if I speak for myself, as a white, a settler, doctor, and a professor at the university, I hold a lot of privilege and I hold a lot of power. And I need to sort of work at dismantling or using that power to dismantle some of those power structures that cause inequities.
Give us a real concrete example for our audience. Tell us how bias and inequity plays out in a particular healthcare setting.
Well, I'm going to give you a very salient example. Just recently, Dr. Cheryl Barnaby in Calgary, with a group of other Indigenous researchers, did a study looking at bias in the emergency room. And, their results confirmed what we have already known and what so many Indigenous patients have been expressing and telling us, which is that they do not receive the same priority and the same treatment when they present to the emergency room. So what their study showed was that when Indigenous patients presented in urgent care or emergency department for the same complaint, they were prioritized as a lower priority. They waited longer in order to be seen, even when they were presenting with urgent problems. So, it's what the patients have been telling us. Yeah. They won't go to emerge unless they absolutely have to, because they know they're not going to be treated as seriously. So they wait until things are really, really more extreme before they present. Yeah. There's also, other data showing that Black patients do not, that the treatments offered to Black patients for pain is less than the treatment offered to white patients with pain, and that there's a belief by some physicians that Black people don't perceive pain as much, which is just horrifying. And there's lots of other examples of really studies showing inequities in terms of how the care that is offered, that certain groups present to care later and have worse outcomes, and definitely with the Indigenous peoples in Canada. Yeah, who unfortunately have more often have a greater rates of arthritis and more severe disease, but receive less treatment and have worse outcomes. And have a much harder time getting to someone like yourself, for example, yes. Getting to the right specialist. All of that is heartbreaking, and I'm so encouraged that you, ACE, so many of us in our arthritis community are now on the path to reconciliation, to action, to address bias and inequity. When, we have a lot of arthritis health professionals who tune into this program, Dr. Lakay. And so if you could, let's spend the rest of our few minutes together here talking about real practical solutions, things that clinicians can do to make it easier for people who do face inequity, who do face bias that is well documented, as you've pointed out, across the transom into their clinics every day. Help share your experience and your expertise and your growing expertise. I know you say you're not an expert, but I'm learning. You're learning by doing, and I think that's just so valuable. It's all about action. So tell us what action folks can take. Well, I think the first action is your work on yourself. So, and we've already talked about this, you need to do the personal work to identify and work on your personal biases. And then you have to try in your day-to-day clinical work, identify those biases. So you should have situations that create little red flags in your brain, this little red alert that we always talk about in medicine. So, when you have gut reactions to specific things, challenge that. Because maybe that's the result of a bias. So, challenge all assumptions. And before sort of assuming that a certain patient isn't going to be able to afford physiotherapy, for example, or isn't going to want a certain treatment because you think they're averse to taking medications. So challenge those assumptions. Never act on assumptions. Ask, you can ask in a sensitive way if you suspect that maybe they might be less inclined, but always ask, never assume. Right. Suspend all judgments, revise your conclusion based on facts. Don't go on gut feelings and impressions. Use facts, use evidence, ask the questions. Another thing that we talk about, because of these studies showing that what we offer can differ, have a systematic approach. A systematic approach reduces systemic biases and racist way of delivering care. So use standardized procedures, use checklists, so that way the care you offer is the same for everyone because you've gone through a systematic process. And then, if you do recognize that you've said something or done something and that you've actually done a microaggression, recognize it, own it, apologize for the impact, not the intent. So because you didn't mean to doesn't take the hurt away. So talk about the impact. You can say you didn't mean to, but don't dwell on that, talk about the impact and then rebuild, reconnect. So that's kind of at a personal level. And those are just some ideas. I'm sure there's a lot of, other ways. And then look at your policies, make sure that your policies and your way that your practice functions it has no systemic bias in it, that your policies are mindful of some of the barriers that certain group face. And
so this includes when I walk through the door, what's hanging on your walls, how you're greeted at reception, the materials that are sitting on your waiting table.
Yeah, so those are, the examples you give are really important. I was getting at, in terms of policies, more things like some people have, if you have a no-show, you don't come back.
Right.
So those kinds of policies, I think those need to be applied with caution. But you're right. What you're talking about, and is a really other important point, is making our practice inclusive. How do we make our practice welcoming and inclusive to the diversity of patients? So, those visual cues are very important. Make sure that and people who faced inequities are looking for those cues, because so many times they faced microaggressions and they've been uncomfortable. They're on the lookout for those cues that tell them, oh, this is a safe place.
Right.
This is a place where I will be treated with respect and equity. So the things I say might sound little, but they actually go a long way. So having pictures that reflect racial diversity, that reflect same-sex couples, that have a diverse vision of a family, having symbols of equality symbols, Black Lives Matter symbols, rainbows, orange shirts, those symbols that give those cues, Indigenous art, those symbols are important. Having
non-specific gender bathrooms, for example.
Yes. If you have control over that, having gender neutral bathrooms, but also how making sure, they say like the first contact with the reception at your office is really important. So making sure that your receptionist greets people and asks about their pronouns, about their preferred names, the pronunciation of their name, and then that you have a system so that it's flagged, so you don't keep asking or making the same mistakes all the time. That goes a long way at creating a culture of inclusivity, of dignity, and of respect, and making sure that you have an equity statement and that it's visible and that it includes gender orientation, gender identity and sexual orientation, and also making sure that it says what's people's recourse if they're not being treated in an equitable way in your practice. So, those are all
fantastic ideas and not beyond ideas. They're actions people should be taking to make certain that the environment people like me walk into is welcoming to everyone. I have to say, I'm listening to you, Dr. Lakay, and I'm thinking back on my 32 years, and I am white. I am who would be considered privileged. And I think about how hard patients work the minute they walk through the door to be liked, to do everything they can to dress the part, like to make sure they're taken seriously. So patients walk in sick with significant diseases, and they're the ones working to try
Yeah.
to get this equitable care. And it's
Yeah.
so wrong. And
Yeah.
I'm so heartened to hear all of these things that the health professional community can and should be doing to
Yeah.
make sure I don't have to work so hard. And I'm using I loosely here, obviously.
Yeah.
That patients who do face inequities, racial bias, gender bias, that they don't have to work so hard coming in when they're not well.
Yeah, I agree.
Yeah.
We should be the one doing the work.
Yeah.
I completely agree.
You know, when you think about sort of the way forward with your colleagues, obviously holding more workshops, doing learning through your medical school curricula across the country. What are some other things you think that health professional associations, like the one that you belong to, the Canadian Rheumatology Association, patient organizations like ours, what do you see as some of the things we can be doing individually and as a collective?
Well, I think, it was very encouraging to see the theme of this year's annual scientific meeting being about moving towards equity in rheumatology care,
Yeah.
because I think the first thing that as a professional organization we can do is working on awareness. Until people are aware that a problem exists, you can't fix a problem. So I think awareness, I think advocacy, I think continuing to document and publish, because unfortunately, just impressions are not enough, and having facts that back up what the stories we're hearing and the things we're seeing are very powerful. Data is a very powerful weapon because it's what drives change and drives agenda. So I think we can be involved in documenting this. And then I think, but we also need policies. We need policy change. I think we have to do work at the individual level, but also at the system level if we want to change systemic racism and systemic discrimination against other groups that face inequity.
Yeah.
There's other strategies that, for example, right now, there's a great movement towards virtual care that's come out of COVID-19 and how it's changed how we practice rheumatology. Well, let's leverage that and let's use these opportunities to also, if used carefully and being mindful of the potential to increase inequities if people don't have access to the technology that allows to do virtual care. Virtual care also has really the opportunity to reduce a lot of health and to reduce some health inequities. So, I think this is, but we have to have very specific policies as to how it's used, et cetera. And I know that the Canadian Rheumatology Association has been very involved in that field as well, sort of having some guidelines. But I think, we need to work and partner with government, with organizations, and with patients. We have to have the patient voice at the table, and we need to have the groups who are facing the inequities represented at the table when we are speaking and when we are devising those solutions. So, because it's their lived experience that is going to tell us all these different ways that we're unaware of that are actually increasing those inequities.
Yeah.
So I think, I'm sure there's more, and I'm sure when we end this interview, I'll think about
You'll think of 20 other things. Yeah. Yeah.
But, off the top of my head, those are just some low-hanging fruit, I guess.
Yeah.
But I think we also have to recognize this is going to take work. This is going to take time. This is going to take commitment. And we have to commit to not just words and educating and workshops, which are important, but they're only the beginning bit. Unless this is also translating to change in policy and personal involvement, where each person agrees to be an active ally. So an active ally, so someone who acts, we're not going to change this. And so it's going to require a concerted effort where we work at all levels to make those changes. and the professional organizations just need to go along and do the work.
Yeah, it's that it's gonna rip off Nike, just do it.
Yeah.
Sometimes you have to act without, you have the essential facts you need, which is inequity exists, it's significant, and it
Yeah.
really affects people in a negative way. For us as a patient organization, those are facts enough to act, right? And
Yeah.
then you continue to collect facts and data along the way. Dr. Lakay, I want to thank you so much for spending time with us today to talk about bias, what it is, how it plays out in the healthcare system, and what healthcare professionals can do to begin to address it from their side of the healthcare delivery equation. You know that Arthritis consumer experts will steadfastly work with you in this effort. We have led a number of initiatives ourselves. We'll be giving some more information at the end here on a slide, links people can visit. We'll direct them to your website as well to learn more about this area of work at ARC. And I just want to thank you so much for your commitment to addressing inequity in arthritis care. We really appreciate it.
Well, thank you, Cheryl. And I know that this is something that really matters to you. And I also really want to acknowledge how thank you for doing that work. And it's a pleasure to be on that learning path with you, and with and for the people who are facing inequities. Thank you.
Thank you, Dr. Lakay. Have a great day, and we'll see you again.
Bye-bye.
Thanks everyone for tuning in to the #CARthritis channel. Bye for now.
Bye.